Central versus peripheral anticholinergics. The clinical puzzle. Here are two patients receiving anticholinergic drugs. A 70-year-old man with COPD inhales ipratropium. His breathing improves, yet his mental status remains completely normal. Another patient receives scopolamine for motion sickness. Within hours, she develops confusion, restlessness, and even hallucinations. Both are anticholinergics. Why does only one affect the brain? The key factor that distinguishes central from peripheral anticholinergics is blood-brain barrier permeability. This permeability depends on the drug's chemical structure. Tertiary amines are lipid-soluble, allowing them to cross the blood-brain barrier easily. Because they enter the central nervous system, they produce central nervous system effects such as sedation, confusion, or hallucinations, in addition to their peripheral actions. In contrast, quaternary amines are permanently charged and polar, so they have low blood-brain barrier permeability. As a result, they remain outside the brain and produce peripheral effects only, making them useful when central adverse effects are undesirable. Therefore, whether an anticholinergic stays in the periphery or penetrates the central nervous system is determined primarily by whether it carries a permanent charge. Central anticholinergics. These drugs are lipid-soluble tertiary amines, which means they readily cross the blood-brain barrier. Once inside the brain and spinal cord, they block central muscarinic receptors, producing effects on the central nervous system in addition to their peripheral actions. Common examples include atropine, scopolamine, and trihexyphenidyl. Because they act within the CNS, they can produce central adverse effects such as confusion, delirium, hallucinations, memory impairment, and sedation. Clinically, these effects are especially important in elderly patients who are much more susceptible to anticholinergic-induced cognitive dysfunction. Therapeutic uses. Central. CNS penetration is not merely a source of toxicity. It is also the basis for several important therapeutic applications. In Parkinson's disease, drugs such as benztropine and trihexyphenidyl reduce tremors and rigidity by restoring the balance between dopamine and acetylcholine within the basal ganglia. In motion sickness, scopolamine, also known as hyoscine, acts as a highly potent central antiemetic by blocking muscarinic receptors in the vestibular pathways. Finally, some first-generation antihistamines, particularly diphenhydramine, have significant central anticholinergic activity, which contributes to their sedative effect and makes them useful for insomnia, while also treating allergic disorders. Peripheral anticholinergics. These drugs are permanently charged quaternary ammonium compounds, meaning they have a polar structure. Because of this, they do not cross the blood-brain barrier, so their actions are restricted to peripheral tissues. Common examples include glycopyrrolate, ipratropium, and tiotropium. Since they have minimal or no CNS penetration, they rarely produce central adverse effects. Instead, their adverse effects are primarily peripheral, including dry mouth, blurred vision, tachycardia, urinary retention, and constipation. Therapeutic uses. Peripheral. Because peripheral anticholinergics do not cross the blood-brain barrier, they are ideal when we want muscarinic blockade without central nervous system effects. In the respiratory system, ipratropium and tiotropium produce bronchodilation, making them important drugs for COPD and as adjuncts in asthma. In the gastrointestinal tract, Drugs such as glycopyrrolate and propanthyline reduce secretions and relieve intestinal cramping. In the genitourinary system, oxybutynin and tolterodine relax the detrusor muscle and are used to treat overactive bladder. If you remember only one line from this video, remember this. Quaternary equals charged. Charged drugs cannot cross the blood-brain barrier, therefore they remain peripheral.